Penny and I have a long history of combative,
yes.
enjoyable professional development, shall we say.
And debate.
And debate, that's the word, no, not combative. So I'm Sue. Sue Johnson, Professional Officer at the Society of Radiographers, Diagnostic Radiographer. I've been in this role longer than I've been in any role, so I'm not sure what that says, but I still feel like I'm learning. It's been my absolute pleasure to have led the support workforce work for the last couple of years, and that's what we're sort of going to talk to today. Richard talked about the feedback. Now, what I'd really like on the feedback is for everybody to say, why was she there? I knew about it all. So I hope that I'm preaching to the converted, but if you are the converted, and as Sam was saying earlier, please, if there's one thing you do when you leave here today, ring a friend and say, do you know about this project? And if they don't, bring them on board, because Kerry's absolutely right. If we don't do this together, it's not going to happen. We haven't got a slide telling you what we're going to talk about, but you might think we'd collaborated with the previous two speakers. More to come. I'll pass over to Penny, who's going to introduce herself.
Okay, so I'm Penny Owens. I used to be a radiology general manager for about 30 years, so quite a long time ago. My last post was Director Allied Health Professionals and Healthcare Science. That taught me a lot. And I also chaired the National Occupational Standards Review for Radiography. So all of those things make me the radiography expert advisor, which is a bit worrying, really. I kept wondering, how does all this come together? But Sue assured me it would be fine. And so here we are. So, if you don't know, this is the project that we started in 2020 with Health Education England. It's been an absolutely fabulous project to be involved with, and I know that there's lots of people in this room who are also involved. We were lucky enough to have Professor Richard Griffin, who is a Professor of Healthcare Management, King's College. Very ordinary, grounded sort of man. I was quite surprised to discover he was an economist by background. Don't hold that against him, now I know that. But definitely a support worker expert. He's done lots of work with nursing and midwifery and absolutely gets the benefit and the value that support workers bring to healthcare support. And he has really helped us in the project. So myself, Penny and Richard form a happy little trio of people who are sort of leading this work together. We had a list of considerations that we needed to sort of consider, funnily enough, can't think of a better word. But it is about that workforce supply, isn't it? Sam was talking about doing things differently, and why do we just, why does culture not change? And there's a phrase that was attributed to Einstein that said, if you keep doing things differently and expect different outcomes, that's the first sign of insanity. And we do just keep doing things differently. I've been having these conversations for 20 odd years. Penny's going to talk about the same conversations for 20 odd years. But I was at a nuclear medicine conference earlier this year, and actually somebody turned that statement round, which I really liked, because they said, actually what's happening is we're all doing everything differently and expecting the same outcome. And they're right, aren't they, with the support workforce? We're all doing it differently and trying to get to the same outcome. So this work is about standardising. Our colleague from Alliance up there was talking about, well, the CQC challenges, how is it safe? Well, the safety is in there being a national standard, and that we're all doing it the same, and that it's audited, and we've got the education that underpins what we're doing. And that's what this project is about, if it's about anything. So we've got some outcomes. I'd like to think that you can all quote me from these documents. Please tell me you can. If you haven't read them, then that's today's homework. The one in the middle is the absolute one that is telling us about the support worker roles. We set up an expert group, employers, support workers, people from Health Education England. We also welcome people from Wales, Scotland and Northern Ireland, because we're an inclusive organisation at the SOR. On the left, the Allied Health Professions Support Worker Framework. Again, if you don't know that framework, really important to the work of AHPs. We're not doing this alone. This isn't diagnostic radiography saying, we're different, because we're not. We have the same challenges as everybody else in terms of getting that support worker education and training in place, standardising roles and responsibilities.
The difference for us is that we don't fit quite so well in that therapies bit. We're more scientific, a bit like Kerry was saying about the advanced clinical practice. That's not where we sit in that whole sort of healthcare pathway. So we're needing to forge our own way a bit in trying to sort of interpret that framework into our document. And because Richard is an academic, and I'm not, we have the supporting success literature review and some surveys that we did to support that middle document. So it's not just the finger in the air, it's not just the Sue Johnson show or even the SOR show or the Penny Owens show. It is supported by what patients want and what we need. So there have been some consequences. I'm not allowed to jump up and down and say how excited I am that we are retiring the scope of practice of assistant practitioners. It's been around for a long time. It was of its time. It served its purpose. But actually, all it says is they can't do this, they can't do that. What we need is to say assistant practitioners can do this and they can do that, and this is the safe way that we do it. So that's part of what we're defining in this work, much more enabling. Can't quite remove it straight away because there's aspects within that document that we still need, but we're trying to sort of gradually change the culture from this is the disabler to this is the enabler. Can't wait for our education and career framework for the radiography profession to come out. We will be including over time the support workforce within that work because actually that's where some radiographers will come from. So we need to embed them in our education and career framework. I've just realised how many people there are here. How lovely to see you all. I'm seeing people looking at me and I'm not used to it. Cameras normally go off and there's no mute button. So yeah, how weird. But we will be embedding that within that education and career framework. And so we will be able to see, and there's some really powerful stories about support workers, how they are supporting the profession. We're not where we were 30 odd years ago when I started. We won't ask Penny how long it is since she started. You know, we've got the technology, we've got completely different pathways, we've got completely different governance systems, we've got a quality standard in imaging. For goodness sake, let's capitalise on that and stop saying no and start saying yes. I told you I won't say what I said I was going to say. Passing over to Penny.
Thank you. The NHS was 28 when I started, so it gives you some idea. I'm hoping the radiation, low-level radiation, helps keeping me less wrinkled. It works for the tomatoes in Sainsbury's.
We didn't practice that either.
No. So we are excited to be here because actually you're the guys that make things happen. The imaging managers, the radiology managers, the lead radiographers out there are the ones that are actually make your department succeed or otherwise. And no pressure then. And it is like pushing that boulder up a hill every day, all day. And with the pandemic, it's just worse. However, we have to plan our way out of a crisis, and this is the time to plan our way out of this one. It's really important to get that workforce element right. And as everybody said to date, the money's there. So this is about how to get hold of the money and to expand that workforce. Because only by developing the local workforce locally and using those skills for the support workers and thinking about how we can embed them across a 24-hour, 7-day service, actually we'll be able to plan our way out of this. We knew it was creaking gates before the pandemic hit, so I won't go to the figures here. This is from the Richards report. Conservatively, I think this is conservative. I think normally, you know, you work on a basis where you need to make sure that you've actually got more than sufficient staff. In order to be able to make this work, you have to worry about things like, well, there's mandatory training, there are all sorts of things associated with that, but actually, with the fact that you're losing so much workforce capability, probably nearer a 30% relief capacity, I would imagine, than this typical 21 to 23%. So something to bear in mind, and also think when you're putting forward your business cases for backfill, that actually those figures probably would resonate. There is a chasm between the workforce that we currently have and what we need. And this is actually about getting creative. So we have been gripped by the opportunity to speak to you. There are two things I would say, and I'm going to read this bit because I need to get it right. Recommendation 18 from the Richards report, alongside the necessary expansion of key professional groups, all relevant organisations should work together to deliver changes in the diagnostic workforce. Particular emphasis should be given to driving skill mix initiatives across the whole country. So this is a national approach. Praise the Lord. I think it's really important that we actually do something nationally rather than piecemeal and finally get rid of the competition. Recommendation 12, additional training places should be provided for radiologists and radiographers, and initiatives will be needed to meet demand, as well as expansion in assistant practitioner and the support staff roles. So again, really important, and we've been quite gripped by that, haven't we, to make sure that whatever we do has a good practical base, that the governance is weaved in. Not everybody who is or becomes a support worker wants to progress to become a radiographer, a sonographer, a mammographer, advanced practice. However, there is significant evidence out there that there is a hunger for it, and insufficient numbers to make it a viable pipeline into the profession. There's a comment here from the expert group. I shan't read it out, but after, when we implemented the 4-tier structure in 2002, I think in the Midlands, that was when we did it, there was nowhere for these guys to go, and I still feel that terrible guilt that actually what happens to the assistant practitioner, they hit that glass ceiling, they've got to then take that time out, as we all know, that journey to become a radiographer, a mammographer or a sonographer. This is a different route, and I think it's important that we embrace that. Developing a pipeline or a practical route into supporting the profession involves developing the workforce profiles. And so the job descriptions have to be aligned to those workforce profiles and also aligned to the requirements of HCPC and SCOR recommendations for education and training. The National Occupational Standards and the NHS Knowledge and Skills Framework are there to support that process. The National Occupational Standards, or NOS, describes the skills, knowledge and understanding needed to take a particular task or job to a nationally recognised level of competence. They focus on what the person needs to be able to do, as well as what they must know and understand to work effectively. So the NOS are the building blocks that we've used in order to be able to pull together the skill sets that would be required at the different elements specified in the work that we've produced earlier on. So I've put it up here because I think it's worthwhile saying that what is the difference between the assistant practitioner and the diagnostic radiographer? I don't think it's clear for everybody, and I think it's very similar to the difference between the radiologist and the advanced practice reporting radiographer. The diagnostic radiographer in this situation has a wider scope of practice, they can do it all, whereas the assistant practitioner has the narrow scope of practice, and that then moves forward in regard to the, I'll use the NHS bandings, band 3, or the senior support worker, or the support worker, generally speaking, band 2. So again, it's thinking about those skill sets, what would that person be able to do, and that narrowness of practice is important. The same thing with the radiologist. The reporting radiographer may report within a certain bandwidth, and the radiologist would report along a wider bandwidth. So it's just the same principle. In my own department, in a previous life as a radiology manager, we realised, I think there's an ex-MRI lead out there somewhere from Derby, I know he's moved on. Hello. So we realised that 40% of the activity was MSK, coming through MRI, and so therefore that lent itself beautifully with back-to-back scanners for assistant practitioners in MRI to be developed, and there were quite a lot of them. I'm not quite sure how many there are now, but there were about 9 at the time. So that's a reasonable number. And that was developed locally, that course, with the School of Radiography up in Derby, and it worked really well. in order to be able to support that practice. So it's about thinking, well, what would my department look like? Because as we've discussed earlier on, there are small general hospitals, and then there are the tertiary centres, and so the workforce and therefore the profile of demand would be different, and that would be unique to you. Sue?
So this shouldn't be news. This is the career structure. I can remember being asked at an interview around about 2004 to describe the career escalator, and with the exception of the mammography associate, I guess this was pretty much what I would have described. Did I ever deliver it to any of the staff I managed? I'd like to think that I did. One or two people managed to progress, but actually it was them that made the progression. It wasn't me. I might have helped with some facilitation. This is what we've got to make flow for those that want to flow. So you'll notice, Kerry talked about the Band 2 clinical support worker. They need to be educated and trained to work. You're not born knowing how to care for somebody. You're not born knowing about radiation protection. Well, I certainly wasn't. You need to be taught the knowledge, you need to get the knowledge so that you can actually deliver the right care to the right patient in the right place. This is a message we've been trying to give to some of our colleagues in the education environment who don't really get why we need radiography-specific education. But when we deconstruct what's being delivered and say, well, actually, we can't get a support worker to demonstrate their role in nutrition in diagnostic radiography because we don't manage nutrition in diagnostic radiography. And they sort of go, oh, all right, oh, okay. But because that's part of the apprenticeship, you have to be able to show that that's what they do. And it's pointless teaching people things that they're not going to use. So our senior clinical support worker level 3 that Kerry's asked you all please to sign up to be trailblazers for, justify my existence, we've been pushing for this, please, please, please do sign up, is going to be around what do that level 3 senior support worker, what do they need to know around MRI, CT, ultrasound, all of those aspects, so that actually they can deliver more, they can do QA, they can help the radiographers in positioning, rather than just being purely, I'll bring them in, I'll tell them the name, I'll tell them the radiographer's going to do this. It needs to be much more robust in terms of their skills. Mammography Associate Practitioner Level 4 is very specific to mammography. That's a role that the breast screening service has developed to deliver the breast screening service. We're not anticipating developing lots of other level 4 roles. Now I know that there's a whole support workforce out there that don't have this level of education and training. We really need to be careful that we don't disenfranchise them. We don't want them all to leave. What we want to say is this is where we want to get to with our support workforce. But we recognise what you bring to the organisation, we recognise what you bring to the service, we recognise your experience. So our assistant practitioner, band 4 typically, is going to be a level 5 qualification, 2 years of foundation degree. Where do we go? Where do we go to get that confidence? How does a radiographer know that they are delegating to somebody who knows what they're doing? It's that qualification, and they will do it as well as we do as radiographers. Narrow scope of practice, do it as well as we do. So you will have the confidence that they can do that. You can work alongside them. You're still the regulated healthcare professional. You're still taking responsibility for the episode of care, but they are responsible for what they deliver within their remit. Now we know that assistant practitioners work brilliantly in plain film, general radiography. I still don't know what the correct term is for that. But we should be using some of that to sort of expand them out into perhaps theatre roles for the less complex cases, for the more routine cases. And we should also be recognising that, you know, if they work all their time in A&E and they're doing horizontal beam lateral knees because that's the technique, that's not an adapted technique, is it? That's a routine procedure for them. So we need to be much more open in our thinking about what they do. But we're heading for that band 4, level 5, 2-year foundation degree. We're not there yet in terms of getting that delivery, and I'm looking at Kerry saying, that's our next challenge, Kerry. We've got to get there with that for diagnostic radiography and also therapeutic radiography. Then we move into that band 5. You can get there from a senior support worker straight into that pre-reg programme, or you can come through the assistant practitioner route and get an accelerated route to diagnostic radiography. That's the vision. That's where we want to be. That's where we need to be. So what happens next? Well, it's in your hands, not mine. This is where we hope to move to next. Kerry's talked about the apprenticeship development. One of the things that Health Education England is asking of all professional bodies is that we make our guidance documents available to all. We're not all managed by diagnostic radiographers at the top AHP level. Actually, at the College of Radiographers, we're already pretty good at having our guidance documents open to all, but there's now a website where we can lodge those things, so we're making use of that facility. Exploring in phase 2, which is just starting, that potential for a national curriculum. It's not really quite the right term, but that education modelling that says this will be the same across the whole of England, but actually this will be the same across all 4 countries, so that our support workforce can move around to other jobs. It's not just patients who move, is it? It's the workforce who moves around as well. And you can employ somebody knowing that they're going to do the job that you want them to do. We do have to think about radiotherapy. I don't have to think too hard about it, but we do have to think about it in terms of how we incorporate them into this work. And then we also need to make sure that we've got that quality assurance around the other roles, around things like CT/MR, nuclear medicine and DEXA, because this is the workforce that's going to allow our advanced practitioners and consultant practitioners to thrive. We're looking for tests or pilot sites. If you're interested in coming along and getting involved, then please do come and have a chat. If you haven't got the time, then please invite a friend. We want to see, as an outcome, that people are progressing into those pre-reg education roles, be it through apprenticeships or traditional routes or whatever. That's what we want to see. Phase 3, I'd love to say that will start this time next year, evaluating success. I doubt it, might be a bit longer. But we should have an evaluation process where we have a look back at what we've done. How are we getting it right? Is the education right? Do our support workers feel it's right for them? Are they able to confidently deliver their roles? And are we seeing service expansion because we've got those support workers in place? I like this handing over the clicker.
Yes, it reminds us what we've got to do next, doesn't it, really? I think, yeah, if you look at that, I won't read it out to you, but I think it's really important that we empower people to work at the top of their practice. One thing I learned from the healthcare scientists, they had modernising scientific careers. That skills escalated from band 2 right through to band 9. They had that, well, over 12 years ago, and we've yet to achieve that. So I think it's important that we're able to consider all of these areas to make sure that we get it right. I would say that a changed skill mix allows everyone to deliver to the best of their ability with the right support in place. The days of the single-handed radiographer outside of core service hours delivering a service to some of the sickest patients in the hospital alone should be numbered. As support workers should be embedded in a 24/7 process. It's a thought to leave you with. Radiographers should have the capacity to deliver more advanced skills as a support worker workforce grows in confidence and ability in order to be able to support them. For patients, they'll see improved access to services, consistent skill and care regardless of the location of the examination or intervention, and a reduction in waiting lists to improve outcomes. That would be, for me, the mummy test, and something I want for every patient. And as I get increasingly into my dotage, it's something I want for me. Okay, so really, I think it's important to talk about safe working practices, appropriate delegation and supervision, and that's something that we're going to be focusing on really within the next a bit of work. But it's important, and I think we've said this earlier on, that as a radiographer we feel confident about delegation and supervision, and that the support worker feels confident that they know what the rules are, where are the boundaries, what do I do, how am I going to be supported, and is there any feedback, so that we don't just delegate and leave, because that way lies disaster. I think it's really exciting to have all you guys in the room, and I'd say please join the reference group. Help us take those final steps for this new workforce delivery, because it is a new workforce delivery, and I think if we can do it all together, it's hard because you've still got a COVID daring do out there, but I really think now is the time and now is the opportunity for us to be able to make that skill mix work for whatever department you come from. Some examples that we thought about would be senior theatre coordinator. If you've got a senior radiographer up in theatre, there's no reason why they can't coordinate a team of APs. That support workers could undertake QA. Why can't they, with the appropriate level of training, safety training? We know that with the latest innovation is that APs are undertaking screening mammography, remote without direct supervision from radiographers, using a mobile phone, which is marvellous. I mean, if they're all packed up, even better. But you know that CQC have said, yeah, we're happy that that's an appropriate form of delegation. This is quite novel. I believe CQC are in the room, and so I think, you know, we should be negotiating. We should be doing this together, because they're radiographers just the same as us, you know. And we should be able to utilise that working hand in hand with the regulator in order to be able to make this work for us and for patients.
So really, just to reiterate that, you know, we've got some great enablers, we've got some really good, clear ideas of where we want to be, but we also know there's a whole host of challenges, and that's where, you know, we need to come together to sort of try and work through some of those. For all that Dr. Hare says workforce isn't the problem, the fact that there isn't enough, you're spending a lot of time trying to recruit workforce, seeing people leave, bringing people back in. It's a, you know, it's a long churn, isn't it, of that workforce turnover. But it is about that cultural change. It is about that thinking differently, so that we can develop that skill mix. You know, we know that there's not hundreds of radiographers out there, but actually there's hundreds of people, thousands of people who probably want to be support workers. So, you know, can we capitalise on that, and can we access that education and training to get that change in skill mix to help us with the workforce numbers? But what we do need to know is that we're getting it right. Now, we've got our nice little reference group, not such a little reference group, we've got our growing reference group who are working with us, and they're sort of talking through us that this sounds about right. Next phase of the work, definitely embedding patients in there, and we've got some patients from one of the national patient organisations who are going to come in and work with us to feedback whether it feels right for them. Does it feel safe? Does it feel appropriate? And what do they want to see sort of in that skill mix of the workforce as well? We've got the support of the AHPs as a whole, and I really have to say how much I value that. We have a much louder voice as an AHP group than we do just as radiographers, and I'd like to think that we have a loud voice as radiographers within the AHP group. Well, we definitely do. Charlotte is very vocal, as is the rest of our team, in terms of sort of promoting where radiographers sit. So we can develop as much guidance as you like. Alex and myself, we can sit down and write guidance to the cows come home, can't we, Alex? But what we can't do is implement it. That's your job. But if we're not writing guidance that you want to implement, then it's not going to happen. So we need to be working together to make sure that what we're saying is absolutely what you want to deliver and what your patients need. That's the bit that we've got to keep coming back to, isn't it? What do patients need? So this is your call to arms. There's no passive sitting at this conference, for goodness sake. This is get involved. This is the joining in. Like I say, if there's just one thing you do, speak to a colleague. Do they know about this? Speak to your AHP lead. Do you even know who your AHP lead is? Who knows who their AHP lead is in their organisation? Woeful. Absolutely woeful. Seriously. If you don't know, I'm sorry, but it's true, isn't it?
They probably haven't got one.
Well, but there will be. It might be a nurse. It might be a nurse. We don't hold that against them. Go and introduce yourself. Say, hey, I'm a diagnostic radiographer manager. There's this work going on. How do we do it? This is the message that you've got to give. Our colleague up there from the Midlands was talking about how do I get the message over. You talk to people. What did we used to do in Derby, Penny?
We used to argue a lot, Sue.
We used to argue a lot. What did I used to say to you, Penny? I said, have you told anybody, Penny? And she'd say, oh, there's a good idea. I didn't do the telling, she did the telling. Much more diplomatic than me. You can tell. But you know, this is what you've got to do. You've got to have a voice, and you've got to go and tell people, this is what we're doing, this is what we need, and this is what our patients need. So please, come and join the reference group. It's not an onerous job. You will get the occasional email Some of you may even respond, which is always lovely, but at least you're getting the information. We have an online forum where you can chat. We do have some support workers in that group. If you've got support workers who you think would be interested in contributing, please ask them, do they want to join the group? Let's get them involved as well, so that we're absolutely making sure we're getting this right. Volunteers pilot site. Sam was talking about the regions. If you don't know your regional lead radiographer, have we got any regional lead radiographers here? Oh, yes, sorry, Lizzie, I'd forgotten you. Sorry. But I think you're the only one. If you don't know your regional lead radiographer, then you need to know them as well. And you need to be telling them what you need and what they need to be feeding back to the national team, who is sitting down here. Quite a limited team at the moment, Kim, but yeah, so, you know, and Sheila, sorry there, I didn't see you there, Sheila. So you need to get involved, you need to be making your voice heard. Come along, volunteer, promote the professional needs. Tell people what we need in terms of education and training for the profession. We probably haven't got time. We haven't got time for the microphones get switched off. There's no mute button. No mute button.
I'll press the mute button.
Come and have a chat to us on the stand. Email us, get involved, because if you don't get involved, then it's not going to happen. So thank you for your time and attention.